single antigen beads, it allows a degree of quantification and correlates well with the cross-match results. So this is the solid phase assay to detect antibodies. That's the commonly used one. But in the past, there was a panel reactive antibody referred to the portion of the cells in the CDC, as I mentioned. And it did measure the current and the historic serum, depending on how the cell panel reflects the donor population. It's largely redundant now in modern practice. In the UK, it's termed calculated reaction frequency. And the definition from there was based on sensitization. So a sensitized patient would be having a PRA between 20 to 80%, up to 85% in the UK. And above that, largely was classified as a highly sensitized patient. Based on the anti-HLA antibodies, for example, in the UK, patients on the transplant waiting list are screened every 3 months for the anti-HLA antibodies. Their immunological risk would be assessed according to these antibodies. So high level of donor-specific antibodies are likely to produce a positive cross-match, and the unacceptable antibodies against the donor would make that as well, which will classify the risk and introduce and explore strategies to reduce that risk, whether that's a desensitization or a donor exchange program. Negative HLA antibody screen doesn't mean no risk. It will be just low risk. But also identifying and monitoring the anti-HLA antibodies on a regular basis allow the virtual cross-match. So why we do cross-match? Because it confirms the presence of the antibody against the donor HLA type. It prevents hyperacute rejection and reduce acute rejection happening. It tests the patient's serum against the donor lymphocytes, whether that from a spleen or lymph node or peripheral blood, and facilitate immunological risk assessment. Cross-match also could be through a CDC, flow cytometry, or virtual cross-match. So the CDC is the donor lymphocyte and the recipient serum in the presence of a complement activation. And if there is lysis of the cell, there will be positive cross-match when transplantation cannot happen. So positive reaction, antibody bound, complement activation, cell killing, no transplant, while in negative reaction, no antibody bound, no complement activation, and no cell killing. So no patient antibody against the donor, basically. It's a test like a transplantation test tube. Flow cytometric cross-match is an antigen antibody binding assay, fluorochrome target antibody, where the increase in fluorescence detecting the binding. It's more sensitive than CDC cross-match. Many programs use the virtual cross-match, and the basis of the virtual cross-match is reviewing the donor HLA type and the recipient antibody profile to predict the cross-match result. Antibody negative patients with adequate antibody screening and testing history can proceed to transplantation before an actual cross-match result available. And that immensely can help to reduce the cold ischemia time and allow proceeding to transplantation. So a recipient with a well represented history of the antibodies profile, HLA antibody profile, would be able to have a virtual cross-match and proceed. This is just a report, actual report from our center, where in Manchester it shows that there's a positive cross-match. It does say, well, obviously the HLA, the match grade and the mismatch, and then a positive flow cytometry and a positive cytotoxic cross-match, and clearly say this is a high immunological risk. And it says down there, the summary, that the flow cytometry and the CDC both positive, to which antibodies are donor-specific antibodies. This is another report from our center for a virtual cross-match, and it clearly says and identifies that the potential donor and recipient mismatch are HLA-A31, for example, and B18DR13. The patient was mismatched for these HLA antibodies during pregnancy. There's no evidence of patient antibody to the repeat HLA mismatch. The HLA antibody data indicate the potential recipient name above has no donor-directed antibodies and can proceed to transplant workup without a cross-match test. So it's a virtual cross-match based on the antibodies, identifying that there is no donor-directed antibodies. So we can see how helpful is the virtual cross-match. This is also extract of the HLA tissue typing and matching between, for example, patient A, donor Z and Y. It tells you here the blood grouping of the potential recipient, blood group A, and the HLA typing, and the donors, blood group O and B, and tissue typing. So for example, if we take donor Z as a potential donor to potential recipient A, then donor Z can donate because it's blood group O, and there is HLA mismatch between them, 0, 1, 1. While donor Y is blood group B, so there is ABO incompatibility. So they cannot donate unless there is ABO incompatible program or desensitization program, or enrolling into the national sharing scheme for pair pool and exchange. This is another donor recipient compatibility summary, saying that the recipient, this is the recipient, blood group O, and the daughter and the son-in-law willing to donate, they are blood group O and B, and obviously only the daughter can donate directly. And then you can see here the HLA mismatch, you can be just 1 in A mismatch, 1 in B, and in DR also another mismatch. So it's 1, 1, 1 expected between the daughter and the father. And the report also, as we get it, it says clearly that the donor, the daughter can donate directly and saying the mismatch, while the son-in-law should be enrolled to a pair pool program or ABO compatible transplantation. It also says the HLA mismatch between them. HLA incompatible transplantation, the classical, if there are antibodies, HLA antibodies directed against the donor, the recipient. But there are sometimes there is a historical antibodies or has a historical positive cross-match, whether Luminex positive currently or historical positive cross-match, and a current CDC negative cross-match. And that's probably will put the recipient in a high immunological risk category. So if we based it on the immunological risk, as we mentioned, there is a high and low, and there is also intermediate in between. So the high risk category would be the potential recipient with a high level of circulating donor-directed antibodies. In the second transplant or third transplant, likely there will be antibodies. When there is also highly sensitized recipient, to start with knowing that the VRA is more than 80%. Mismatch in the GR, HLA GR, more than 2 or 2B, 1 GR would be classifying as intermediate to high risk. And if any of these resulted in a positive cross-match, transplantation cannot proceed unless there is a pre-transplant desensitization technique. The low risk is the no or low levels donor-directed HLA antibodies, either not detected or very low levels. And we said if there is no, doesn't mean no risk. And when the DR mismatch is less than 2, then that's classified as low. And there is an intermediate between the two, where in between, rather than a high induction and augmented immunosuppressive protocol is used compared to the low immunosuppressive regime in the low standard or the low risk category. There could be intermediate in between as well. Based on immunological risk, either the patient or potential recipient will need a preconditioning desensitization, whether that's HLA incompatible transplantation or APO compatible, and there is different techniques of how that could happen pre-transplant, or no preconditioning with a negative cross-current, negative cross-match, whether that's historical positive or previous donor-specific antibodies, but has not resulted in a current positive cross-match. I will quickly review the outcome of these immunological risk and the HLA incompatible and ABO incompatible transplantation, also the mismatch in the GR. So if you look at that first data from the collaborative transplant study, we can see that as more GR incompatibility or mismatching, the worse graft survival. 6 mismatch would have a poorer graft survival compared to no mismatch in HLA. Still transplantable, but probably need to be aware of the poor graft survival and then take into consideration the patient, the recipient age. So it does matter, for example, for a younger patient having a kidney and likely to have more than one kidney in their life compared to an older recipient who would possibly just have one kidney, and that's probably would be of less importance and would be a good option than staying on dialysis. This is the 3-year graft survival data from the NHS blood and transplant, and it shows you the different types of living non-highly sensitized patient or living highly sensitized transplantation, ABO incompatible transplantation, diseased non-highly sensitized and diseased highly sensitized, and then the worst graft survival outcome is the HLA incompatible living and HLA incompatible disease. But you can see even the worst of them, which is the HLA desensitization incompatible transplant from a diseased donor, that still have about 80% graft survival over 3 years. So still better than staying on dialysis, and I will show you this data shortly as well. That also has been shown from a different group in Coventry, showing that living donation, HLA incompatible transplantation, disease donation, and AP compatible transplantation are really comparable in terms of 3 years transplant survival. So in another word, we can see that this data clearly say that desensitization and preconditioning pre-transplant to allow transplantation would be better for the recipient and have a better survival compared to staying on dialysis or staying on the waiting list. Thank you. I'm happy to take questions.
Ayman Kamal for this elegant lecture, and I think we open the discussion for discussion. Dr. Kamal is with us online or no? No, not online. Okay, so we'll shift to the next speaker. دكتور أمان.
هو دكتور ايمن از اون كول دلوقتي فقال لي مش عارف اخش معاه اونلاين.
مش عارف يخش. اوكي.
Now we come to the case presentations, and the first case will be presented by Dr. Ahmed Elsawi from Maadi Military Hospital. Fadel Tura.
السلام عليكم. يشرفنا الانضمام لحضراتكم. I will present this case. Mr. Y, 48 years old, known to be hypertensive, on medical treatment uncontrolled due to lack of compliance. He passed to end-stage renal disease by 2019. He presented to us wishing to undergo renal transplantation, so he started to search for a related matched donor. The patient was generally fit for undergoing renal transplantation with some concerns. Obesity grade 1, pan-reactive antibody was positive in class 1, 12%. So the first potential donation was his wife. There is HLA typing showed single matched DR loci, one loci in HLA DR. So I would like to ask about your experience about transplantation from such donor with single matched DR locus. Unfortunately, there is positive cross match, and the DSA was positive against the HLA 33. So the second potential donor was his sister. Regarding their tissue typing, there was 3 mismatches, 1 matching in DR and 2 matches in HLA-A. But also, unfortunately, their initial cross-match positive B lymphocyte with DSA against CW12. How can I prefer this donor? Was positive cross-match B lymphocyte.
Any answer, Professor?
What? Another one? Repeat the test. Can donate.
We can take the sister. Number one, in this case, we have a PRA was high in the first one, and also DSAs, and the cross-match positive for B lymphocytes not a contraindication. The most contraindication for cross-match positive, T lymphocyte positive cross-match.
Okay, but the outcome, it will lead to antibody-mediated rejection later post-transplant or the survival of graft.
مش طايله. We have let me put some points. لا أنا هتعب. Okay. Merci. Okay. This patient have 2 donors. If I have a pool of donors that I can choose from it, I can put all of them and choose the best one. If the only 2 donors are available, his wife and his sister, and the only sister having low tetra DSA, and his cross match is still positive, but only for B lymphocytes, it will be the best even she have a mismatch on all HLA. But if I have the another one who have 1 match on DR, but very high titer DSA, cross match positive B and T, it is absolutely contraindicated unless done desensitization protocol.
Okay, okay.
Thanks.
But we seek for better donor.
If you're having the pool, you can proceed.
Yeah,
if
yeah.
you have exchange donation, have proceed. If you have a paired donation, you can proceed. And it will add to you to do what is called HLA matchmaker. It will help you, and the C1Q, a single bead, will help you more to put other risks for this patient to do better risk assessment.
Okay, exactly.
Do you agree, professors? Okay, continue. For this notion?
يعني search for better donors I think is better.
Okay. We seek for better donor. So his brother was the third potential donor. There is 3 mismatches, 2 matches in HLA-DR and 1 matched in HLA-A. Okay. But again, there were also DSA against CW12. We revised the immunologies, so he decided to repeat the DSA test again for his brother using single antigen peptide technique depending on measurement of MFI for DSA locus. If MFI was 1,600 non-significant with negative cross match. This is the summary for his donors.
بتعمل له الفلو سايتومتري كروس ماتش ولا لا؟
بنعمل ايه يا فندم؟ موجود.
الفلو سايتومتري هو اللي نيجاتيف ولا
هو هنا كان السي دي سي.
ها؟
كان السي دي سي يا فندم.
انما انا سؤالي ما بتعملش الفلو سايتومتري لان هو الموست انديكاتيف اوف ذا سرفايفل اور جرافت سرفايفل اوتكم هو الفلو سايتومتري.
الفلو سايتومتري بنعمله في الاخر يا فندم فاينل كروس ماتش.
I would advocate ان احنا نعمل الفلو سايتومتري تو اساس الايشو اوف ذا دي اس اي لان هو مش سيجنيفيكانت اصلا 1600 دي.
تمام. So we proceed in renal transplant, but another problem appear as final cross match revealed the negative T lymphocyte and the positive B lymphocyte. We repeated it again twice, and the final cross match was negative for both B and the T cell types using CDC cross match. So we proceed for the transplantation. Risk assessment for this case based on CDC cross match and antibody screening was intermediate risk. Although induction with ETG, patient presented with delayed graft function. Patient was anuric after the operation and stayed like that for 5 days, and the hemodialysis was done from the first day. Renal biopsy slide. There are focal mild glomerulitis, patchy moderate tubulitis, focal mild lymphocytic infiltration, which reveals that there is antibody-mediated rejection, C4T is positive, acute T-cell mediated rejection, BANF2-BF. He received 5 sessions of plasmapheresis, alternating with hemodialysis. ETG total dose 500 was given. Rituximab 1 gram was administered. After 5 weeks, serum creatinine returned to 1.5. During 2 years of follow-up, there are no major complications. Serum creatinine is stable on 1.5. There is a course of hospital stay, plasmapheresis, ETG, Absira. Discharge prescription as shown. And thank you.
Excuse me, Dr. Ahmed. I think there is a question in the operative details. I think this patient has prolonged schema time, as I remember.
There is a major complication.
Yes, this is maybe
in the operation. Prolonged ischemia time.
This may explain or maybe a reason for the development of ABMR, not just the immunological risk before.
Professor Gamal, you have any comment?
I'm asking about your ETG dose in this patient. Do you using the low dose or high dose ETG for induction for this intermediate risk patient?
ETG?
You do induction pre-transplant in this patient.
Induction.
By ETG?
ETG.
Yes.
1 to 2 milligram per kg.
1 to 2 milligram per kg on low dose, less than 7.5 kilo.
كنت عايز اكومنت على حاجه حضرتك قلتيها. معلش اسم حضرتك؟ شيماء. الدكتوره شيماء، حضرتك قلتي لو كانت البي سيل بس كروس ماتش هو اللي بوزيتيف از نوت اوف سيجنيفيكانس. اتكلمي في الميكروفون عشان هناقشك في الحته دي.
In English please, Dr.
And in English.
I'm not saying not of significance. It is significant but not absolute contraindication. If I having patient and I doing desensitization protocol and I fail to get totally negative BNT.
البي ان تي مع بعض هو المهم والتي اهم من البي، صح كده؟
بالظبط كده.
موافقين. بس معنى ان يطلع بي بس بوزيتيف از نوت تو بي نيجلكتد. and we should perform ايه بقى؟ لما يطلع بي بس سيل بوزيتيف it indicates ان في ايه؟ non HLA. ولازم نعمل ايه بعد كده؟ لما الاقي non HLA الكروس ماتش المهم اللي بعد كده ايه؟ اللي هو نون HLA انتي بوديز، والسيريز بتاعتها الدكتور مدحت الدكتوره ميرفت يقولوا لنا عليهم لان دول مهمين. هل اتعملوا هنا؟
لا نون HLA انتي بوديز.
لان ده مهم لما يكون في عندي انديكيشن اوف اي انتي بودي برودكشن ويز بي ار اي ولا وات ايفر بوزيتيف، والكروس ماتش بارتيكولار فلو سايتومتري لو كان نيجاتيف، وفي عندنا شك في اي حاجه من السي دي سي كان بوزيتيف، وشود بيرفورم ذا نون اتش ال اي انتي بوديز، ومنهم كتير قوي انتي اندوثيليال انتي بوديز، وهم اللي ممكن يكسبلين الديليد جراف فانكشن والانتي بودي ميديتد ريجكشن.
Dr. Gamal, please in English because we have already a foreign guest online. In English. Speak in English totally. Okay.
When the B cell cross match is positive, we should perform non-HLA antibodies. Oh, in English. مش انجليزي ده برضه يا هو ده انجليزي.
Any comment from the professor on the stage? Professor Mai?
Thanks, Dr. Gamal.
Professor Askar, please, if you have any comment.
So I'm very surprised that you see all this pathological change with the isolated C DSA of 1600. And single antigen beats can give false positive reactions. So we really need to look at the pattern and make sure that this is even a real antibody. And usually in our lab, when we see antibodies that doesn't seem to be consistent in reactivity patterns that we have seen over the years, we do other forms of Luminex assays, such as phenotype beads, which have multiple antigens on the same bead, but if they include CW12, they should be positive. If they remain negative, then that's it. And my other question is, what type of CDC cross-match you do? Is it the NIH CDC or is it anti-human globulin CDC? Is it extended incubation or multiple washes? What type of CDC?
التايب اوف سي دي سي ده كان مع الاميونولوجيست معانا في المعمل المركزيه، ف اي ثينك ان السي دي سي الاوردينري بتاعنا.
اوكي.
لازم نلجا للسيل بيزد انتي بودي تيستينجز whether the lymphocyte or endothelial cells، لان هم دول اللي ممكن يديتكت other antibodies other than the Luminex. لان اللومينكس انتيجين بيدز ممكن يمس many of the epitopic antibodies, epitopic antigen direct antibodies not represented على lymphocytes.
True. So the HLA antibody testing by beads will only detect HLA antibodies.
Yes.
There is a dedicated Luminex-based panel for non-HLA antigens.
But this is not the usual Luminex.
No. I don't know what you mean by usual.
It's not the usual antigen bead, the single antigen bead Luminex اللي احنا بنشتغل عليه لل.
It's a separate product on the market. You purchase and
it's
you
a separate kit.
It's a separate kit.
Yes.
For non-HLA antibodies. But one thing we need to be careful about when we casually use the term non-HLA antibodies. We do not use this term when we find positive cross-match that is not explained by single antigen beads. We call it not due to HLA antibodies. We do not call it non-HLA antibodies. The reason is the non-HLA antibodies that are known to be clinically consequential, such as MIC-A antibodies, AT1R antibodies, endothelial antibodies, they are not expressed on lymphocytes. So they cannot explain positive flow cross-match. Positive lymphocyte cross-match.
Excellent conclusion. Yeah.
Thank you.
Thank you, Professor. Any further comment from the audience or professors on the stage? Professor Annie, you need to add anything? Okay, we can move to the next speaker, please. شكرا دكتور أحمد، شكرا ألف شكر.
The next case presentation will be presented by Dr. Mahmoud Nadi, Ain Shams University. دكتور خالد سمير، عين شمس يونيفرسيتي. اتفضل دكتور خالد.
Welcome. Today our case is about patient SM. She is 35 years old, male patient, a female patient with no special habits of medical importance. The patient presented to us seeking for renal transplantation. She is known in stage renal dialysis for 7 years. The access was right distal AV shunt. The etiology of end stage, the patient had recurrent UTI due to vesicular reflux. Due to small neurogenic bladder. She had the meningocele on birth, and she removed it, and since then she had neurogenic bladder and remained CKD for the almost her life since started to be on dialysis 7 years ago. The patient is known also hypertensive for the past 7 years. After 2 years of dialysis, the patient became HC positive and received the treatment, and now her PCR is negative. The patient is known also osteoporotic for the past 5 years. In 2017, after receiving treatment of HCV, the patient had anemia, hemolytic anemia, and she received 4 units of washed, filtered, irradiated backed RBCs. Her body mass index is 17.7 kg per meter square, and her donor was her sister, 32 years old with fair medical history, and her body mass index was 20.7 kg per meter square. The basic labs before transplantation wasn't significant. The patient was anuric for the past 2 years. No urine access was done. Hepatitis C, البيشنت PCR negative. Cytomegalovirus status, البيشنت IgG positive, and her donor also was IgG positive. Renal ultrasound, left kidney not seen. Right kidney is shrunken. HL typing, no mismatch, matching 6/6. PRA, first PRA was done was on May 2017.
The identical. دول identical.
لا مش identical. في فرق 4 سنين. لا, the patient 34 years and her donor 32 years.
No problem. Can be.
No mismatch. The matching was 6/6. Her first BRA was done in May 2017. It was 10% positive and at 37.4 degrees. After 9 months also was repeated and remained 10% positive. On that period, the patient was receiving a tour. After 5 months again, in July 2018, the BRA was negative on class 1 and class 2. And repeated again also 4 months ago in November 2018, it was also negative. And then in October 2020 also negative. And the last one was in August 2021 before the transplantation, it was also negative. Her CDC cross-matching in August 2020, in total allo it was 10% positive before TDT, but negative before after TDT at 4 degrees, and negative before and after at 7 degrees. Second was done after 1 year at last August. It was negative on before and after TDT at 4 and 7 degrees. Her final cross-match was done 1 day before the renal transplantation done. It was allo. It was negative before and after 4 degree DDT at 4 degrees and 7 degrees, but on the total auto it was 15 to 20% positive before DDT at 4 degrees and negative after DDT, and also was 15 to 20% positive before DDT at negative after DDT at 37 degrees. Her immunosuppression in induction, the patient received 3 plasmapheresis sessions on day -3 and -5 and -7 before the transplantation. And also the patient received 1 gram rituximab on day -1 and received 500 milligram on day +14.
احنا قاعدين مستنيين الانتيبودي ميديتد ريجكشن. We are waiting for the antibody mediated rejection. يعني I am eager for the antibody mediated rejection. توكل. Continue. Depend on God عشان نبقى بالانجليزي.
Also in the induction, the patient received methylprednisolone 500 milligram on day -1 and 250 milligram at the anesthesia induction and 500 milligram on the declamping session. Those was titrating according to outcome, kidney function or urinary output. The patient also received MMF 700 milligram by ID starting on day -2 and started tacrolimus on day 0, 2 milligram BID. Intraoperatively, the patient did bladder augmentation also was done, esophageoplasty with insertion of 2 urinary catheters in the operation. The schema time total was 29 minutes only and adequate urine output. On day 0 at night, the patient received 2 bags of washed filtered irradiated backed RBCs because of the bleeding in the operation. The normalization of kidney function was on day +1. Outpatient clinic follow-up till now. Maintenance immunosuppression she is on tacrolimus and MF and prednisolone, and the dose of tacrolimus adjusted according to FK level. Last labs serum creatine 0.9 and the FK level is 6.2.
هنشوف اللي بعد كده بقى.
Last labs دي 1 week ago. Our question of this case is the patient is positive PRA. For how long should we wait before transplantation, and what would be the best management for the recipient before and after the transplantation? And thank you.
ده ما حصلش انتيبودي.
دكتور حضرتك تحب تعلق على الحالة، على السؤال عرض الدكتور خالد سمير؟ اوكي.
هو الفكرة ان you should continuously monitor for the DSA and the titer لأن you are expecting an antibody mediated rejection with the history of the PRA, and they always mention that the peak PRA before transplantation, not the immediate PRA, the historic PRA is more relevant to the possibility of occurrence of antibody mediated rejection. And I think you should be anticipating it and continuously maintaining the patient on a higher tacrolimus TRAP level, monitoring for the DSA, and you should consider boosting for the rituximab لأن الرituximab is a short-lived anti-B cell. مش عارف في البروتوكولز اوف ماونت سيناي، ولو الدكتور مدحت يقول لنا في امريكا بيعملوا ايه بالنسبه للريتوكسماب اندكشن. اتس نوت ا سنجل دوز وخلاص. هاو frequent you should boost for it مع السيتويشن ده.
دكتور مدحت you have answer?
الريتوكسماب boosting is it only a single dose pre-transplantation with history of PRA positive ولا you need to booster every how long? Do you use obinutuzumab طيب؟ أو bortezumab؟ أو IVIG؟
حضرتك إذا هو ما فيش donor specific antibodies و negative flow cross match, which my suspicion in this case will be, we wouldn't actually give them augmented immunosuppression. They would just go on the standard protocol. This is first transplant, right?
But he did plasmapheresis before. He treated as a high-risk patient.
And actually, I'm not sure why plasmapheresis was even given in this case.
Okay.
Yeah, in our practice, that wouldn't be a candidate for plasmapheresis. I wasn't sure what was the indication for plasmapheresis in this case.
The positive PRA يا دكتور مدحت يعني هو anticipating ان في antibodies.
But he did single antigen beats and it was negative for class 1 and class 2, correct?
The last 4 were done negative.
And it is HLA matched. So this is not just 6. These are 2 haplotype matched because these are siblings. So they are almost guaranteed to be, unless there is a recombination in DP or something. In all likelihood, this is going to be HLA identical. So plasmapheresis and HLA identical in absence of donor-specific antibodies on single antigen beads, in my mind, seems a little bit unjustified.
Okay, Professor Yasser, you need.
All of us know that there is major antigens. HLA, B, and DR, there is minor, and sometimes antibodies against these minor HLA, like epitopes, and sometimes part of the immune system to be attacked by antibodies. The presence of positive cross-match per se is an indication of the presence of antibodies in this case.
But historic, Dr. Yas. Historic.
No, it's at the time of final cross match.
The final كان positive.
Final cross match was positive. 15%. 15% cross match 1 day before the transplantation.
They signify what Dr. Medhat was mentioning, that you need to perform the flow cytometry. Cross match, and it would be more relevant to the percent of positivity.
Yeah.
آه.
But once it's positive cross match, and that's why I dealt with it as
to be considered.
desensitized patient, and that's why I used plasmapheresis and two doses of rituximab, not single dose, one day 0 and the other one after 2 weeks. And according to the progression of the case, we can say if we are needing more or not the use of rituximab or plasmapheresis.
Okay, في any question or even comment
دكتور
from
مدحت عايز
the
يكومنت.
audience?
تعال انت عايز تكومنت قول.
You
حاسس
need to
بيك.
comment, Dr. Medhat?
I think we need always to keep in mind that lymphocytes express other antigens other than HLA. But they are not the antigens that have been documented to be associated with antibody-mediated rejection. And the conviction among immunologists is that positive lymphocyte cross-match in absence of donor-specific antibodies is not associated with increased immunologic risk.
Let me differ with you a bit, يا دكتور مدحت. Even if they are not anti-HLA and they are non-HLA, if the DTT is positive and indicating that it might be IgM, it might be relevant.
Regardless whether it is IgG or IgM, there are known non-HLA antibodies that have been documented to be associated with antibody-mediated rejections, like anti-endothelial, anti-MAC-A, anti-AT1R, anti-EATR, and it's a whole host of none of them is expressed on lymphocytes.
لو B بس ولا B و T?
B and T. So the conviction, and actually it's a white paper from the American Society of Histocompatibility and Immunogenetics way back when in 2002 that establishes that positive cross-match of any sort in absence of donor-specific antibody is not associated with increased immunologic risk. And we need to keep in mind that the false positive rate in standard CDC cross-match is significantly higher than flow cross-match.
والعكس لو if the DSA is positive, MFI less than 3,000 and the cross-match is negative.
That's an important point. There is a literature to document that if you have, so the antibodies are hierarchy, are a continuum. So if you have antibodies that are very high to cause legitimately positive CDC cross-match, this is like way back when, in probably 10 years ago or even 15 years ago, there was this protocols at Mayo Clinic and at Cedars-Sinai and at Hopkins where they were transplanting positive CDC cross-match. 5 years outcomes were horrible and everyone stopped doing that. So no one is doing that anymore. They were associated with increased graft loss, increased patient mortality, because the second level of antibodies would be antibodies that would cause positive flow cross-match. So those are associated definitely with increased graft loss, increased patient mortality. Antibodies that are not strong enough to cause positive flow cross-match, but they are present by single antigen beats, are known to be associated with increased graft loss, increased risk of graft loss.
Okay, في online question discussing the indication for desensitization for this patient. Anyone have any comment? Dr. Yasser, why this patient receive desensitization? Why? He write like this. This is online question.
Yes, again, this is a positive cross match in day -0 or -1 before transplantation.
Yeah, this is your opinion.
With a positive history of PRA more than 80%.
Yes. Okay.
In the history. And
Dr. Askar, I think, has another opinion.
And something else here in this specific case, this patient was a high risk surgically. We are not expecting any complication with the immunological risk besides this. The patient stayed in the OR for about 12 hours.
Yes.
Yes, high. And this patient will continue on self-castration for life because she has neurogenic bladder. We are not waiting to expect any other complication beside this surgical problem in this case, and that's why we are covering immunologically in order to prevent any occurrence of rejection or something, which will need during her course of post-transplant period to use immunosuppression to heavy doses to correct whether antibody mediated or other cause of indication.
So justified?
Yes.
Okay, Dr. Askar, justified the desensitization or no for this patient?
No, I'm not going to comment on that. No. I'm not going to comment on that. I would say what we would do in our center. So if they are HLA identical, which we test all our patients by allele level typing at all loci, at 17 loci. So we would know that they are HLA identical. Then really cross-match and DSA, all of this becomes irrelevant in our way of doing things. Unexplained positive flow cross-match, then we wouldn't give augmented immunosuppression. We definitely wouldn't plasma freeze. We wouldn't do any of this. But what we would do is that we call this unexplained positive cross-match. And we would monitor for DSA on day 7 and day 30. And if there is, and as far as I remember, in the last 5 years, when we did this, only one case showed increased donor-specific antibodies post-transplant, which really may have not been related. I mean, we were not monitoring everybody else. We could have monitored everybody else who didn't have that, and one of them could have turned it to have donor-specific antibody. But that's what we do. We would monitor them diligently, but we would not augment their immunosuppression or plasma freeze.
Thank you.
Dr.
Thank you.
Medhat,
Dr. Hani?
I want to, does the presence of infection explain sometimes this unexplained positive cross-match?
Yes.
Because
so we see this all the time with HIV.
That this patient has doing self-catheterization and has possibility of recurrent infection. This could be the cause of persistent positive cross-match in absence of the other factors which necessitated that Dr. Yasser did the plasmapheresis. But maybe if the control of the infection, the cross-match would have been
so we see
otherwise.
We see this unexplained positive infrequently with infections. We see it very commonly with HIV patients.
Yes. But the patient was anuric in the last maybe 4 or 7 years. Anuric, there is no urine outcome, no UTI. Expecting after transplantation to be self-catheterization after transplantation, not before.
But with this self-catheterization, would you increase the immunosuppression doses?
And that's why I hope we'll keep the immunosuppressant at the lower limit as possible. Yes, she's under antibiotic.
I believe the issues we are
changing the pH of urine in order to control the UTI.
I believe the issues we are discussing are not yet finalized and settled, and they are still debatable. And the experience in the Spanish school, Dr. Medhat, they consider even a 90% positive PRA not an indication for desensitization, and they proceed with if the DSA is negative with a positive PRA, مش 80%, 90%, provided the cross-match is negative. The other way around, the situation which we have now is that we have a positive cross-match with a negative DSA. So this might be a bit query situation, an awkward situation, and I would not oppose very much the plasmapheresis, and I would have added IVIG, مش rituximab, because the patient has infections and so on.
Okay, دكتور باز يحب يعلق؟ Okay, أي حد يحب يعلق؟ I think by this fruitful يعني discussion and session, we need to close this session, and I think we will go to coffee break. Thank you all.
We will come back at exactly 5:30. احنا عندنا السكيدول عشان الفورنر اللي معانا. We will start exactly at 5:30 please. عندنا دلوقتي ساعة إلا ربع. for coffee break, for prayer, for whatever you want. Thank you very much.